I don't know why the elimination of this curable disease has eluded us, but it has been my objective for very many years. The latest WHO Global Tuberculosis Report shows that the current estimated incidence of tuberculosis in 2020 was 10 million. Now, if you go back, as I have been doing to the figures, you will see that figure of 10 million has not changed at all, in spite of us having a curable disease. And as they say, TB is one of the top 10 causes of death. The estimated incidence is about 10 million, of which 1 million are children. This is the estimated incidence, of which undiagnosed are estimated to be 4 million. And TB kills nearly 1.5 million every year, of which 250,000 are children. TB kills nearly 5,000 people daily. And the prevalence of multi-drug resistant TB is about 5%, and it's rising. And of that 5%, 10% are XDR. So what are the drugs that we have? Well, you all know the existing drugs, which are shown on the screen, isoniazid, ethambutol, pyrazinamide. The group of rifamycins, of which current emphasis is on rifampicin and rifapentin. We also have the quinolones, which in 3 trials showed that it did not reduce TB duration to 4 months, but trials are still ongoing with quinolones. Now, what about the new drugs and repurposed drugs? So we have a whole lot here, of which bedaquiline is probably the one that's known to you. But bedaquiline has taken 22 years to come from discovery to marketing. Now, if all the TB drugs are going to take that long to come to marketing, we're going to have to spend a lot of money, and that will be beyond the means of most TB programs. Now, let me tell you about the first short course chemotherapy when I started research in tuberculosis. At that time, many of you will remember that the duration of treatment was 18 months, which consisted of 2 months of streptomycin, thiacetazone, and isoniazid, followed by thiacetazone and isoniazid. And although the duration was long, the relapse rates under trial conditions were very, very respectable, 3% relapse rate, but the duration was the obstacle here. So we started a trial doing 6 months of therapy. And here you can see we used streptomycin, isoniazid, and the relapse rates were catastrophic. So clearly that could not be rolled out. We added a third drug, thiacetazone, and again, the relapse rates came down only very marginally to 22%. But when we changed the third drug to pyrazinamide, we had a very significant drop in relapse rates. And when we changed it again to rifampicin, the relapse rates came back to 3%, which is equivalent to the 18-month duration. So this regimen looked very promising. The problem is that it contained 6 months of streptomycin and clearly could not be rolled out. But here again, I did a trial to see what rifampicin part was played in. And when I was working with the International Union Against Tuberculosis in Paris, we did a trial comparing 2 8-month regimens with ethambutol in the continuation phase. But a 6-month regimen with rifampicin in the continuation phase was clearly much better. So there was a 2-month difference reduction, but people were afraid of the expense of rifampicin. And so the standard regimen, after a lot of research, remained as the one you know now, which is 2 months of ethambutol, isoniazid, rifampicin, pyrazinamide, followed by 4 months isoniazid, rifampicin. At this point, thiacetazone had to be removed because we were getting the epidemic of HIV, which was reacting fatally with thiacetazone. So thiacetazone was replaced by ethambutol, and this is now the standard regimen, which was rolled out by WHO in 2003 and remains to this day as our standard regimen. But clearly, it was important for people to complete the regimen, and many of them didn't because it was too long. At about the 3-month rate point, they all dropped, or many of them dropped their treatment and relapsed. So we took another look at high-dose rifampicin, and here was a study of early bactericidal activity. That is the bactericidal activity of rifampicin in the first 2 weeks of treatment. And you will see that the bactericidal activity was shown only when the rifampicin dose rose to 35 milligrams per kilograms. I would remind you that currently we're using only 10 milligrams per kilogram. People were afraid of increasing the dose of rifampicin because, as you see, as the dose increased, so the hepatic adverse events increased. And so the dose stuck at 600 milligrams to this day. However, this was to be proved. And so when I moved to St. George's, I conducted the RIFATOX trial, which was to look at the toxicity of high-dose rifampicin. And this trial compared the standard 4-month regimen with 2 4-month regimens. Sorry, this is the standard 6-month regimen, with 2 4-month regimens containing rifampicin at 15 milligrams per kilogram and 20 milligrams per kilogram. And we monitored these liver function tests very, very carefully and found no increase in hepatic events as the dose increased. This trial took place in Barara, the epicenter base in Barara, in Kathmandu, Nepal, and in Santa Cruz, Bolivia. We had 300 patients across Africa, Asia, and Latin America. And as I said, the increased dose had no increase in hepatic adverse events. Furthermore, neurine studies have shown that increasing the dose of rifampicin from 10 milligrams to 50 milligrams completely eliminated the persisters, which were thought to be susceptible to high-dose rifampicin. So this murine study was, again, very promising. We have already shown it is not, high-dose rifampicin is not increased side effects, and moreover, it cleared the persisters, certainly in mice. So that is when we started the RIFATOX trial, of which many of you are familiar. And here we randomized 672 patients. Again, the control was the standard 6-month regimen. And here were 2 4-month regimens where we doubled the dose of rifampicin and tripled the dose of rifampicin. The inclusion-exclusion criteria for this trial was gene expert, sputum positive, rifampicin susceptible, newly diagnosed cases of pulmonary TB. They had to be 18 years old to give consent. There was some exclusion criteria, of which HIV seropositivity was one. I regret that now. I wish we had left the HIV positive patients in, because if a trial is rolled out, it will have to be given both to HIV positive and HIV negative patients. And the outcome measures of the RIFATOX trial were, the primary objective was to reduce treatment. And so so we were measuring the combined rate of failure at the end of treatment and relapse during the subsequent 12 months of follow-up. Since an increase in dosage might have caused unwanted side effects. We very carefully monitored the grade 3 and 4 adverse events, including the hepatic ones, certainly the hepatic ones. And there were a number of secondary outcomes which we also measured. But these two were key: relapse rates, adverse events rates. The study began in January 2017, and took us a long time to complete our sample size. There was a gap here where we were told to stop enrolling because the coronavirus pandemic had started. But after 3 months, we were given permission to continue enrolling. And finally, we stopped enrolling in December 20. So it took a long time, 3 years to complete enrollment. And this is how we ended with Botswana with 54 patients, Conakry 175, Mbarara really very respectable 224, and we had Lima with 119, Kathmandu with 70, and Pakistan with 30. But Pakistan, I have to tell you, came in later. Otherwise, we would have had more patients. But in any case, we achieved our sample size of 672 patients. We did a persister sub-study for which we don't have the results, so I won't go into those details. You will get them at a later date. The centers participating were us at St. George's, Epicentre Mbarara, the German project in Kathmandu, but University of Botswana, Lima, the Inyas Deen Hospital in Conakry, Karachi, the Shuk and Lahore, and the School of Hygiene provided statistical support. Currently, thus, there are 3 phase 3 trials being conducted on drug-susceptible tuberculosis. Let me tell you that most of the clinical trials are being conducted on multi-drug resistant tuberculosis. So only 3 trials that are being conducted on drug susceptible are the TBTC study 31, of which I'll tell you later, the Global Alliance Simplicity trial, which consists of bedaquiline, protominate, moxifloxacin, and pyrazinamide. The results of these are not yet available. And then there is our inter-TB RIFATOX trial. Now, here is the TBTC trial in which they used rifampicin with isoniazid. And in one arm, they replaced the isoniazid with moxifloxacin. And you can see that the moxifloxacin arm did much better, met the criteria of non-inferiority, whereas the isoniazid arm did not. And they concluded that the regimen with rifampicin and moxifloxacin was as effective as the standard treatment. So at last, we have a 4-month regimen. The problem here is that it consisted of daily rifampicin, which is expensive, but that is no bar to using it. But that there is nobody currently manufacturing rifampicin. I believe that Lupin in India are going to start, but although the WHO are recommending rollout, rifampicin is not easily available for a rollout, a global rollout of this 4-month arm. Then we looked at another trial, which comes up with a really startling suggestion, which said isoniazid adds no measurable benefit during the first 2 weeks of treatment, and regimens should be developed which no longer include isoniazid. What? We have been using isoniazid as a companion drug to rifampicin for decades. And now we're told we shouldn't because it antagonizes the effect of rifampicin. This is really a very startling suggestion and needs to be tested under trial conditions. Here again, when I go back to Professor Grosch's murine studies, you can see he tested various regimens in mice, and in one regimen with 4 drugs, he had quite respectable bactericidal activity, but when isoniazid was removed, the bactericidal activity improved. Here's another clue that isoniazid may be antagonizing rifampicin. And here, again, this is a murine study where they used rifapentin with moxifloxacin and completely sterilized the mice. So that study 31 makes sense to use rifapentin. Only thing, as I said, it is not globally available. Now, when I looked at, my thesis was done on the early bactericidal activity of drugs, where I gave various drugs in singly and in combination to patients with newly diagnosed tuberculosis and measured the fall in colony forming counts during the first 14 days. Other people did other EBA studies with these drugs, and you can see here that isoniazid had the highest early bactericidal activity. So how can we remove that? I mean, when it practically clears the lungs during the first 2 days of the bacteria. So more trials need to be done to test this episode. And yet we have here Dr. Mwangwa of Médecins Sans Frontières to say, yet this disease, tuberculosis, does not receive anywhere near the attention it deserves. Care, treatment, and diagnosis remain woefully unfunded, and I can tell you that from personal experience. And despite the fact the number of new cases being diagnosed every year is decreasing, the overall people living with TB is at an all-time high, as we fail to cure the people already living with the TB. The working group for new drugs have said the world is losing its battle with tuberculosis, which is now the biggest infectious killer globally. And if we continue at this rate, TB is unlikely to be eliminated until the end of the 22nd century. That's an awfully long time to eliminate a tuberculosis disease. Simply, we don't fund it adequately so that we can seamlessly move on from one trial to the next. If we go on at this rate, this is what we will see. Drug-susceptible tuberculosis, this is the number of tablets they have to take. If they develop MDR TB, the number of tablets increases and the pill burden is so high that it is very difficult for patients to take this. And when you get XDR TB, you have to add an injectable. All of this makes administration very difficult. And look at the costs. For drug susceptible, each case TB is $257. When you go up to MDR TB, that number multiplies enormously to nearly $7,000 per case. And when you get XDR TB, it's more than $250,000 per case. I know of no country in this world that can afford. So it behoves us to do everything we can to eliminate drug-susceptible TB so that we don't get cases of XDR TB, which is really a death sentence. Moreover, the Stop TB Partnership has shown that the 12 months of COVID eliminated 12 years of progress in global fight against tuberculosis. So with this pandemic, we've gone back 12 years because research in tuberculosis has been pushed back to the back burner. And I don't think people even know the words TB anymore. So let me end by telling you why this is the case. This is Professor Nabarro, David Nabarro of WHO, who gave the Thomas Young lecture at St. George's, and this is what he had to say.
So the first person to hand up is Professor Amina Jindani. Unmute yourself, Amina.
Professor Navarro, thank you very much for a very, very inspiring lecture. I think you will certainly not remember, but I think we met a very, very long time ago when I was working with Wallace Fox and Denny Mitchison. Now, the 2 A's and the 2 N's, the 4 A's and the 4 N's have really gone towards eliminating pandemic after pandemic very successfully. My question is, why have we failed with this one pandemic, tuberculosis? What can we do? What I see is no networking. In fact, I'm beginning to see competition. Who will get the first 4-month regime? Who will get the first effective vaccine? I think it's sad. This is a pandemic that infects 10 million people every year and kills 2 million people of a curable disease. I'd very much like to hear your thoughts on that. Thank you.
David.
Professor Jindani, lovely to see you. Wallace Fox was our collective guru on tuberculosis some years ago, one of the very best leaders in this area, and just thinking really hard about the situation with tuberculosis right now. It is an absolute scandal. Professor Jindani, you are right at the center of this. You've been involved in these multi-center clinical trials on pulmonary TB. You've managed to show that it actually, if you use rifampicin and other new therapies, you shows my age, doesn't it? You can really reduce duration. And the whole problem with TB, certainly when I was quite young and doing my early work, clinical work in South Asia, TB was this issue where it required daily injections of streptomycin over a number of weeks, and then the rest of the therapy lasting over 18 months under supervision. People felt absolutely awful. They were living often in terrible circumstances, and they were excluded from their homes. And now we've got these shorter therapies, which are very, very. Why on earth isn't TB being dealt with properly? And my answer is threefold. Firstly, TB is a disease of poverty, and I think that we are always facing problems with diseases that mostly affect poorer people. That we live in a world which is profoundly inequitable, and issues that are primarily faced by poorer people too often get shortchanged in terms of political attention and investment. Secondly, the understanding about short courses has been far too slow to get into public attention. When I was in the World Health Organization, we were involved in the development of something called directly observed short course treatment, or DOTS for short, and I think we did not push it hard enough. We should have, because I think that we could have achieved big shifts in the tuberculosis situation probably around that time in the early 1990s. There was a window of opportunity. And then thirdly, more recently, in the international system, we've had a coming together of work on HIV, AIDS, on malaria and tuberculosis. And somehow the successes on HIV, AIDS and the successes on malaria have sort of squeezed tuberculosis into the side. And I remember once I was involved in work with the Global Fund to fight AIDS, tuberculosis and malaria. And I was saying to colleagues, you know, if we are going to really have any kind of legacy as public health experts, we ought to deal with the shame of our failure on tuberculosis, because it is eminently treatable and preventable. There are all the therapies, but we've somehow not let it happen. So I haven't got an answer, but I think circumstances, the poverty focus, the fact that we didn't get the short course in place, and to a little bit the marginalisation in relation to AIDS and malaria has, I believe, left us in a bit of a problem. I see I'm a bit short of time. Sorry.
So there you have it. If you are poor, don't bother, and you have tuberculosis, don't bother to go and see a doctor. They won't bother with you. I think this is really a disgraceful situation. We are very close to shorter chemotherapy, and the lack of funding is just obstructing seamlessly conducting trial where we can get even shorter regimens. I hope the funders will see this and will change their minds and continue to support research on tuberculosis. Thank you very much indeed.